Hey everybody, this is Erica Mello, and welcome to episode number 207 of Tough to Treat. And this is a shorty week, as we say, and it is my turn to do a shorty. So this episode is about exercise progressions, and I know that over the years, God, I think Susan and I have been doing this now for 5 years, 6 years, the podcast. We've often talked about exercise, and so I think what I want to get across with this short episode is when you're selecting an exercise for a patient, whether it's open chain, closed chain, upper or lower extremity, plyometrics, whatever, I want you to think of the level of difficulty it is for the driving region of the body. So, for example, if you have somebody who has foot pain, common, right? And their driver is their foot, and you right out of the box give them single leg heel raises. Is that really smart? I don't know. I don't think so. That's really hard for a foot to do. They need to go there. So I want you to think about sort of the moral of the whole episode is, am I giving harder exercises too soon? Or am I having them do really easy exercises too long? So wherever you are, whatever region of the body you're in, think about how hard is that exercise for that region of the body. I hope you enjoy it. And we would love to get more listeners. Obviously, we have a lot of listeners, a lot of loyal listeners, and we're so thankful. And for any of the new listeners, we really appreciate it. We still would love to get more reviews on iTunes. We have well over 100 now. It really helps with the algorithm and gets us recognized. And we were at a combined sections meeting in February, Susan and I, and it's amazing. It's still, podcast world is so huge, right? And some of the people who were actually in the room listening to us didn't even know we had a podcast. So it'd be great for anybody who really has found value with our content. It would be wonderful if you could even write a couple lines on wherever you listen to podcasts. And for the new listeners, our website's toughtotreat.com. If you have a question on a region of the body that maybe we've done a podcast about, for example, go in the search bar and just type in the region of the body: knee, foot, pelvis. I do that a lot when I'm listening to podcasts. I just go on their website and type in whatever I'm interested in, and up will come a lot of the episodes that we've devoted to that topic. So hope you enjoy it, and we will see you on the next episode. Okay, everybody, welcome to episode number 207 of Tough to Treat. And this is on exercise progression. And for those of you who are listening to audio in whatever podcast app you listen to us, you may want to at some point drop over to YouTube and see some of the slides I have. I have just two slides here. And there's 4 exercises on each slide, and I will describe them. You should be okay with the audio, but I always think a visual is equally important, and sometimes I'm a visual learner. So for those of you who want to hop over to our YouTube channel, it's Tough to Treat, and here we go. So as I mentioned in the intro, you want to think about what regions of the body. Number one, you want to determine what we call, your driver, your primary driver. Okay, let's say somebody comes in and has, a low back pain, very common, and you've determined that the low back is not their driver. It's, let's say, it's their pain generator, but it's not their driver. That their driver is their thorax, for example. Okay, and into let's say middle thorax, right? And they have a long movement history, a long injury history, and they also have a foot component to their problem. Okay, so I tend to see, I think I tend to see many sort of complex patients, but I think the older you get, the more regions of the body we have that can be potential drivers. It makes sense. We've developed compensatory movement patterns. I'm super hypermobile. I can compensate until I can't, but I can compensate for a long time. And I think that just is probably not the best strategy either. So we develop
other areas of the body that are potential drivers. And so it is very, very common to have a patient who has had a long-standing history of what many things, and to have more than one driver. So when you are prescribing exercise, you want to think about, number one, what's the primary driver or drivers? And the exercise program should be geared towards those regions of the body, not the pain generator. Okay, so if they have low back pain and their lumbar spine's not their driver, why would you be giving them, let's say, I don't know, abdominal exercises or, prone extensions? I'm talking about chronic problems here, not acute. Okay. Why would you be giving them, exercises geared towards their pain generator when it's their pain generator, it's not their driver. So, for example, the exercise I'm looking at here is what's called a wall land. And so what you're doing is you're going against a wall, and this particular person has a TheraBand wrapped around her hands, and she's doing what we call a dynamic wall land. So it's literally almost like you're landing on the wall in a push-up position. And so she has one hand above the other, and so she's landing in like a diagonal pattern on the wall. Okay, and she's in a normal base of support. And so if you have a patient who has a thoracic driver or a neck driver or a glenohumeral driver, how hard do you think that exercise is for them? Okay, so you think about it, you're going on the wall, you are in a diagonal pattern, and you're literally landing in a push-up position. That's not easy. It's not horribly difficult either. And so that type of exercise, you wouldn't probably start out of the box with that. You would probably start out with more wall lands, symmetrical, like hands on the wall. Or middle of the road exercise if you're going to do with the TheraBand and the arms on the wall. If your person, for example, we'll use this example still, has a foot issue as well, how hard do you think that exercise that you're giving them is for the foot? Not difficult. They're not really moving, they're standing. They are standing. So a lot of times when I have patients who, have foot components to their problems, and I assess them, and they're very their neuromuscular balance is better with a wider base of support. So you tend to see that a lot with people who have foot issues. I tend to, when they're doing standing exercises, if I haven't cleared the foot up yet, I'll have them stand with more of a wider base of support. So this first exercise here is really a normal-ish base for her, and all they're doing is wall lands, just literally standing, TheraBand around the forearms, and landing in a diagonal pattern on the wall. The way to make that exercise easier is take the band away and have them land symmetrical. So that's not horribly difficult if someone has a neck problem, right? I would start them out maybe first couple weeks doing more of a symmetrical wall land. So that's not difficult. Not hard for the hip, not hard for the pelvis, not hard for the knee, not hard for the foot. Okay. So the second exercise here on for those of you who are watching, is what we call a side. It's like basically this person's in a squat position, and all they're doing is going side to side. So lateral translation. Okay, how hard is that for the neck? People who are listening, you're in a squat position. You're not doing a lunge. You're doing lunges, but you're not picking the feet up off the ground. So you're in a squat position, and all you're doing is going from one side to the other. Right, one leg is being extended, one leg is bent, side to side. How hard is that for the neck? Pretty easy, right? Now you have to hold your head up, but not difficult. How hard is that for your thorax? I would say it's harder than the wall land that we just talked about, because you're training lateral translation. Not difficult, but you need to go through these exercises to get to those difficult ones, right? I'll show you on the next exercise that you would not give immediately out of the box. Okay, so with this particular one, the person is doing a side, I call it squat side to side. Okay, they are deep. So neck not difficult, thorax midland difficult, because you are doing lateral translation. If you're holding a TheraBand in your he has his arms up a little bit with the forearm wrapped around forearm. Oh my lord, with a TheraBand wrapped around his forearm. A little bit hard for the deltoid, but not. He's below 90, not difficult, right? How hard is that for the pelvis? middling, right? Squat's pretty straightforward, but they're not just doing a squat, right? They're going side to side. I would say intermediate for the pelvis. Lumbar spine, not really an option unless they're sitting, and sitting's an issue. You'd have to watch this. Um, how hard is that for a hip? Someone has a hip problem, and you get right out of the box, you're giving them squats with side to side movement. That's hard to do for someone who has a hip issue, especially the side to side. Okay, that's something I would not give right out of the box. Okay, because you are going literally side to side, and you're transferring load to one side over the other, and you're alternating. So that's hard for the hip. What about the foot? So for those of you who are listening, just think about what the foot has to do when the foot goes to the left. So when the foot goes to the left, right, as people are seeing in the video here, that left side has to sort of become a rigid lever, right? It has to support the weight of the body. That right foot should, what we call, fan a little bit. The arch should flatten out, okay? You can see here. So when the person goes right, it's the opposite, okay? So I'll just play this again. So think about squat side to side. Hard for the thorax, not horribly hard, but harder than the wall lands. Side to side, that's really hard for the foot. That's really hard for the foot to do. That's something I would not give out of the box. If someone had what we call a foot driver, I would absolutely not give that exercise, because that's really hard for the foot to do, depending on where you have found the problem. If they have a problem in controlling the fanning, when the person squats, the foot fans out. If they have a problem doing that, you need to train that more into the symmetrical movement pattern rather than loading one side over the other to start. So that's very difficult for the foot and the hip. So if someone has a hip and a foot issue and those are the drivers, I would not give the squat side to side out as the first exercise. Absolutely not. Okay, the next exercise is a split squat with thoracic rotation. Now, this should be a little bit obvious, but neck and thorax, hard, right? Rotation's hard. I know Susan and I talk a lot about in the podcast, getting into rotation, but that's not easy for the thorax to do. Even if your person has knee pain, this may be hard for the knee in general, but if your person has knee pain and they're okay doing a split squat with rotation, this is a very hard exercise to do, a split squat with rotation. This particular person has the right foot in front and the left foot behind. She's in a split stance and she's rotating over both legs. Rotation right, rotation left. How hard is this for the neck to do? Hard, it's rotation. Thorax, hard, it's rotation. She's got TheraBand around her forearm. How hard is that? How hard is that the shoulder, glenohumeral? Not difficult at all. It's a great one to give. Not difficult at all. She's pushing out against the band 5%. She's got, getting a little bit of deltoid involvement. Not difficult. How hard is that for the front hip? She's standing in a split stance position with the right foot in front. How hard is that for the right hip, the front hip? Hard, right? It's almost like single leg stance or in a narrow stride stance. Really hard. That's a tough one for the hip to do. How hard is this for the back hip? The left leg is back. The back hip, how hard is that? Depending on where the impairment is, it could be also quite difficult. So the point is you don't really want to add these split stance positions with these rotational positions as first exercises for most regions of the body. For the foot, how hard is this for the foot? Front foot, not difficult. I mean, she's putting weight onto it. If the person has a problem fanning, getting load, it may be difficult. How hard is this for the back foot? She doesn't even have her heel up all the way. How hard is this for the back foot? Very difficult. This is a very difficult exercise for many regions of the body, probably except for the glenohumeral joint, right? So, and the pelvis, I would say pelvis also quite difficult, okay? Because you are in a split stance with rotation. This is where these people need to go, but think about where the drivers are. If you have somebody who comes in, same thing. If they have a hip and a foot, those are their drivers. This is like not the first exercise I would give out of the box. This would be one of the latter ones, to be honest, okay? Speaking of hips, this is actually just a photo. I see a lot of patients who've had hip issues for many years, and the hip is what we call one of their drivers, and they just cannot access lower abdominals, but they're just overactivating hip flexors. And so what I tend to do is I put their feet up on the wall in the tabletop position. I don't start with the band around their thighs. I end up just basically I progress that. So for those of you who are on the audio, just imagine your patient's tabletop. I put two pillows underneath their bum to take out the hip flexor, and then I have them do bent knee raises, bent knee fallouts to really to help gravity against that wall, go to knee to chest and do the bent knee fallout. I'll progress by putting the TheraBand around above their knees and taking a pillow out. This really is to take out the overactivity. Is this really hard for the hip to do? Not really. It's the first one I give out, right? First one I give out. Okay, last slide here. Sorry guys. Okay, so the last slide is, here we go. This is a supine arm exercise. So if someone has neck pain and their driver, let's say for example, is their shoulder. How hard is this? This one. It's going to be on supine, TheraBand wrapped around the forearms, doing pushing out 5% and doing skull crushers, chest press, and sort of overhead shoulder flexion. How hard is that for the shoulder to do? Really difficult, right? Open. Sorry, I'm just playing this for people who are watching. So go to the YouTube channel to get all these slides, okay, guys? And so what you want to think about is when someone is lying on their back doing a supine TheraBand exercise, if they have a glenohumeral joint issue, that's their driver. This is hard to do. I have a lot of patients who have glenohumeral drivers, and I have progressed them through multitude of push-ups, down dog, and they don't have any problem. But when it comes to open chain, glenohumeral drivers, it's a tough pattern, I have found anyway, to really get them to progress out of this. So I'm well advanced in closed chain with a lot of patients who have shoulder issues, or shoulder drivers, I should say, and then they're still doing supine arm series on the because it's hard for them to really progress out of that to start. Okay, so this particular exercise is geared towards more the thorax, and so if you have a patient who has a thoracic driver, I always start them in this with the supine yellow band arm series, bearing in mind if their shoulder is an issue or it's in their profile, you take it down a bit. I go on hands and knees and I start closed chain. Okay, that's how I would do that. Not really hard for the knee, the foot, any region of the body, but this is a really good one for the thorax. And then you can have them alternate, and to progress this, you would just have them, you can take weights, holding on to one weight, like one weight interlocking, and then you can just progress to single weights, to going together. And then if you want to do alternating arms, that adds more rotation. That's going to be your progression there. Okay, so I would not start somebody lying on their back with 5-pound weights in their hand and having them do alternating shoulder flexion. May seem easy, but that's really hard for the thorax to do. It's rotation. You're going to find areas of imbalance if someone who has a true thoracic driver. Okay, this one here is a side to side, just literally. It's a Franklin band, and this is not your squat side to side. This is just standing. Yeah, this is a. Yeah, sorry guys, you can hear the video. You can hear me on the video. So this one is a side to side with the band. How hard is this? Think about the squat side to side I just talked about. How hard is this for the hip? Thorax. Thorax, I would say intermediate. Once again, it's lateral translation. She's really not moving, but she still is going side to side and has to stack the thorax over the pelvis. How hard is this for the hip? Really hard, right? Watch or listen. She's pushing that right leg out, and then she has to bring that right foot back in. And so she's got a TheraBand wrapped around both of her feet. She's standing on it, and she's bringing the TheraBand back. You may have to go up to the YouTube on this one. This is kind of hard to describe. So then as she's pushing out, she's getting more of that lateral translation into the hip, more wide base. Okay, as she's coming back in, bringing that foot with her in the band, she's recruiting the opposite hip. That's really hard for the hip and the pelvis to do. Okay, and equally as hard for the foot, because you have to develop that rigid lever, as we talked about on the prior video. Okay, I love this exercise with the therabands under the balls of the foot because it really gives your feet some proprioception. You can have them hold a weight, or she's just holding the band in her hands. That will also give you some thoracic input. Okay, but this is a great way to control make good foot control, okay, with the TheraBand and get that eccentric on the way back. Okay, I've just got two more and we're done. Okay, this is a split squat. Okay, so this is the basic split squat. This model has the left foot in front, the right foot behind. She's got a TheraBand wrapped around her forearms. I use the TheraBand around the forearms quite a bit, and she's doing basic bicep curls. Okay, think about how hard is that for the neck? Not difficult. Not difficult, right? So as she's going down, this is a symmetrical activity for the thorax. She's not going side to side, so it's not a difficult exercise for the thorax. Okay, not difficult for the pelvis. Where it gets difficult is when we go to the hip. Okay, that front leg, once again, that's going to be hard for the hip to do. Back leg, you can see here, she's got just a decent pyramid, but when the back foot, the rear foot is up in that plantar, in like the heel raise, that's really difficult for a foot to do. Okay, and so I'm just reiterating what I told you from the other slide. Okay, so this is not so fairly easy for thorax. If the patient doesn't have a foot issue at all and they're good, then this is a great exercise to give early on, because it challenges the lower extremity while maintaining the thorax over the pelvis. She's a little off here. You can see she's a little bit translated up to the left there, but this is a good one to train that control. And lastly, we've got sling squats. Basically, those are just heel raises with the knees flexed and the knees bent. I always start patients there on the wall. It gives them a reference for center. How hard is this for the neck to GH the thorax? Not difficult, right? Their hands are on the wall. They're doing sling squats. How hard it is for the hip? Not difficult. How hard is this for the knee? Think about it. How hard is this for the knee? You're going up in a heel raise. At the top of the heel raise, you bend your knees in one part of the sling. That could be quite difficult and painful for someone who has a knee issue. May not be their driver, but it could aggravate, right? I have found over the years that more lately that the foot needs to get treated along with the knees for people who've had foot issues for a long time. Okay, so the sling squats are not horribly difficult for the feet. You are doing heel raises, but you're supported on the wall and you're doing what we call as a sling. I always have the patient go up to where they can control. If I start to find them going into plantar flexion inversion, they're losing control. They only do the range where they can control. Okay, so but bear in mind that this could be provocative for the knee. Okay, so it would be a harder exercise for the knee. If the person doesn't have any knee issues or it's not in their driver at all, then I would give this fairly early on for anybody who has a foot driver, because it's a pretty easy exercise to do and people can control it very well. Okay, at least when they are shown how to control it. So I could do a whole slew of slides on these and giving, pick an exercise and we can dissect it and determine how hard it is for the driver. But I want you to think about, as I mentioned in the introduction, the moral is basically, if you have someone who, you're pretty confident you've got their drivers now and you're going to pick an exercise, let's say they want to get back to running, right? You need to do a lunge. You need to do some of those, the split squats here, right? You need to do that. It's very important, okay? And if their foot is their driver, you're going to be very careful as to what exercise you choose out of the box, okay? Because going in doing a backwards and forward lunge is going to be really hard to do immediately. I just don't do that immediately at all, especially if their foot is the main reason, right? So I do a lot of other things, but the sling squats are generally the ones I get sort of fairly early, to be honest. And if you're really trying to train center of mass, You can do the squat side to side, and also that I mentioned on the previous slides. And then you could also do the one here with the TheraBand, that where has both of her feet on the TheraBand, and she's challenging that foot control with TheraBand, but she's challenging her center of mass. And so center of mass needs to get treated. Susan and I have talked about this a lot on all of our episodes. You're chronically loading one side, you will increase the risk of musculoskeletal injury. It has been proven. I've done a lot of research on center of mass lately for a project I'm doing. I recently came across something on concussion where, people who are concussed, really have a lot of issues with their center of mass long term. For those of you who took my Decoding the Complex Patient course, you'll know one of the case studies is there a golfer. He got hit by a golf ball twice, was concussed, and his center of mass was so altered. He was hitting the ball off his right leg, and he had knee pain. Once we trained his center of mass and got him back, he was a lot better. That think about that as well when you are prescribing exercise. Susan and I will be together on the next episode, and any questions, feel free to reach out to us. Our email is tough2treatpt@gmail.com.